are people going to be able to join virtually or in person for our ALS working group with the IMPCS meeting in September?
I hope so.
If you can't come in person, we have the virtual option, which we're still trying to clarify exactly what that's going to look like, and how exactly the technology is going to work. But at the very least, there'll be some virtual presentations because we have a lot of international presenters, and then the hope is at least some working group potential for us. So that would be wonderful. That's on Friday, September 20th from 8 to 12 p.m. Grand Rapids time. What's Grand Rapids? Central? Yeah, okay.
Coast. It is, yeah.
Beautiful. We'll give it one more minute and let everyone join who can join. And the only other exciting, keep a lookout. I'm going to send out an email probably in the coming week. Our patient care partner interactive tool that we've been working on to try to kind of pull together all the resources from the existing websites is hopefully we'll have a prototype for review in September. The two AI engineers that have volunteered their time are going to show us the prototype, and we know it's a prototype, so it'll be hopefully desiring input on use and content, and really I actually want it to be useful to all of the partners. So like people living with ALS, both persons with the disease and their care partners, all the clinicians, the advocacy groups, because we're hoping we can house it on their websites. So if you know friends who I'm comfortable with, if you have friends who aren't in this group, you are welcome to forward the email to them to have them join, because I think the more we have, I know there's a point at which there's too many voices, so there'll be more reviews, but so this will be step one. Okay, well, why don't we get started? We have a wonderful talk ready for today. Dr. Christina Rush, who is a staff psychologist at the Mass General Hospital Center for Health Outcomes and Interdisciplinary Research, is joining us today. She also has an academic appointment at Harvard Medical School and completed her pre-doctoral internship at the VA in Maryland, at the University of Maryland, and then did her doctoral training in clinical health psychology at the University of Colorado, Denver. She is an expert and researcher in the intersection of mind-body medicine, religion, and spirituality, and coping with serious illness. And at the Center for Health Outcomes and Interdisciplinary Research, she's on the Recovering Together study that's working on building resiliency and improving emotional distress in neurocritical care patients and their care partners. She's also working on a resiliency intervention for people with ALS and their care partners, and just received a Research Seed grant from the ALS Association and the Cornfield Scholars Program Award from the National Palliative Care Research Center to support her work. So we are just so excited for her to talk with us about her research, about being resilient together in ALS, and her research work that's being done in progress. And it sounds like we're going to have some group discussion. We're going to do a lot of learning. So I'll turn it over to you, Christina. I'm really, really grateful again for you to speak with us today.
Thank you so much for that warm welcome. I really appreciate it. Hi, everybody. Thanks for being here. I'm excited to share this work. And yeah, there's going to be parts where we can pause and have conversation. And this is a small group, so it can be, more flow back and forth if anybody has questions as we go or just wants to share reflections. So I'm going to pull up my slides and then we can get going. So yes, I'm Dr. Rush. I'm here to present on a research work in progress called Resilient Together ALS. And also, if there's time and interest, we can talk about some clinical case examples with this work. And I know you all have a lot of expertise working with this population, so very interested and excited to hear your perspective on all of this too. Here's kind of like a working agenda of things we can talk about today. And again, flexible based on what is of most interest to everyone. So I'll touch a little bit on resilience, what that is, because it can mean different things for different people. We can also talk about things you've seen in your work with this patient population, emotional responses to diagnosis and navigating illness, and then dive into some discussion of coping skills for patients with ALS and their loved ones. And as I mentioned, there could be some case examples there if desired. Also, some thoughts on things that you might already be using in the moment when you are meeting with patients with this diagnosis or their family, loved ones, and additional thoughts on that. And time for Q&A at the end if we want that. So just a little background on how I came to do this work. I'm a clinical health psychologist. I didn't study psychology in undergrad, but like the first few years out of college, I was exploring interests and became really interested in behavioral medicine. And that led me to take a course with Dr. Deborah Norse at American University, who really knows a lot about mind-body medicine and behavioral medicine, and fell in love. And I didn't know for sure because it was all new to me. Like, does this mean I should get a doctorate or not? I don't know. So I chose to pursue a master's degree to keep learning and getting exposure. And during and after that master's program, I also gained experience at the Uniformed Services University of the Health Sciences, an internship at NIH. And then right after my master's program, I decided to take a position as a project director at Georgetown University for an RCT for dyads, Latina breast cancer survivors and their caregivers. And that cemented, like, yes, I love clinical health psychology. This is what I want to do. So I pursued a doctorate with Dr. Kevin Masters at SUNY Denver. And his lab focuses on the intersection of religion and spirituality in health. So that's where I got these concepts of spirituality and how that relates to overall well-being. And then the last part of my training was going to the VA Maryland healthcare system, which is associated with the University of Maryland School of Medicine. And I completed the health psychology track there. And during that training, I did 2 major rotations in hospice and palliative care. And that's actually where I met the first patient ever that I worked with who was diagnosed with ALS. And that was a really powerful experience for me, working with him as well as other people with serious medical illness, seeing that there's a lot that can come up during that time and a need for support as well as skills to help navigate the emotions that can come up when navigating serious medical illness. So this all led to me pursuing postdoc, and that's how I got introduced to Dr. Branchanu here at the Center for Health Outcomes and Interdisciplinary Research. She has a lot of expertise in intervention development for prevention as well, and helping people navigate chronic and serious illness, including neurological illness. So my position that I ended up accepting here was bringing together my background in serious illness and spirituality and her expertise in intervention development. So as I've been learning more throughout the postdoc and now I'm staff here, that I thought it was important to also touch on this term of resilience because it can be used differently by different people and mean different things to different people. So one description of it is the process by which an individual harnesses resources to sustain psychological or physical well-being in the face of stress. So that idea of harnessing resources is important here. And then another description is that resilience is a dynamic and iterative process. So sometimes when people think of resiliency, they might think, okay, you're either resilient or you're not. Like it's kind of a dichotomous thing. Whereas this is suggesting it's actually more of a growth, right? Like you can build it over time. And then another citation in the literature says promoting personal resilience resources, including skills in stress management, problem solving, goal setting, cognitive restructuring, and meaning making may reduce poor mental health outcomes and improve quality of life and health behaviors. So this is, an important concept, and we'll talk more about this too, any observations you may have had. So, a lot of you work with people with this diagnosis all the time, and you have a lot of expertise. So I just wanted to take this moment to invite an opportunity for reflection, things that anyone might want to pause and share about what they've observed with their interactions with patients or their close loved ones that speaks to you as an example of resilience. Any challenges you maybe are noticing with patients and their loved ones. And also, you can take this moment to reflect on how this might impact you and, as a person working with people with this illness or influence the clinic or what, similar setting that you are in. So I'm just going to pause for half a minute. Oh, actually, I see someone raised their hand. Yeah, Ken, would you like to say something?
Yeah, sure. Just a preliminary observation in my experience, both personally and with the wider community of people living with ALS. The single greatest factor that I have found in terms of people's resilience is whether they are committed to or believe that a cure might be out there to save them versus those who accept that they have a progressive and incurable disease and that, once you get to know the science, the odds on anything developing in time to save us is really remote. And so, I have found now that I'm in the latter category, that's actually quite liberating and gives me a great deal of resilience. I focus more on thinking about what I can do in the time I've got left to help promote therapies for the future generation. And it makes me those who are really preoccupied with trying to support research that's going to cure them or gain access to experimental therapies, they tend to be much more anxious, angry, frustrated, and less resilient. That's just been my experience.
Thank you for sharing that. I wonder if that brings up any other reflections from anyone. So, yeah, these are all just things to take in.
Oh, sorry. I think Sarah was going to say something.
Oh, yes, please. Go ahead.
That's okay. I just put my hand up. It's Ken, thank you so much for sharing that. And it's really meaningful to hear your thoughts. I'm a social worker at Emory's ALS Center, and so I strive and hope to provide support to the people that we're taking care of. Something that I notice, and this is just more of how I've been able to coalesce it into words, that seems to be a spot or just a way that I noticed that folks seem to be expressing more ability to have resilience. And I do think it fluctuates depending on sort of what's happening. But in general, I do tend to see folks that have had more of an ability to kind of bounce and move with things than others. And a big part of that for me is summed up in this quote that there's an current day Episcopal priest named Richard Rohr. And I don't know, Christina, if you've ever heard of him, just in sort of this spirituality sort of, place that you've been in with your training. But he has said that if you don't transform your pain, you will transmit it. And something that I see with a lot of folks who so much of this is meaning making and just like you were talking about in the prior slide about being able to find meaning in what's happening, which isn't necessarily an explanation or a why, but finding meaning. And then Ken, on sort of what you were saying about what does this look like for other people, knowing sort of what the landscape is for me. But it seems to me that when folks it's an ability, I think, that they kind of already have. Like, so much of this is, it's not just resilience that you have once you get this diagnosis, but I think a lot of it is, how has your life been before, and sort of what level of resilience have you had prior to this diagnosis? And if they've been folks that have sort of been in that place of being able to transform the difficult things that have happened in their life in a way that has been able to add meaning for themselves and for people around them and their community. And that seems to, for me, that's sort of what I really kind of noticed.
Yeah, I love that, like helping them find what's already there and use it in this new situation. Is that a fair summary?
Mm-hmm.
I don't know if Sarah heard my question. But yeah, thank you both so much for sharing those reflections. And I'm just double checking. I don't see any further hands, so I'll keep going. But yes, please feel free to keep the discussion coming. Oh, there's something in the chat. Let me just check. Kelsey, would you like me to read this out loud, or do you want to share?
It doesn't matter. Sorry. Here, I'm still here.
Yeah.
I was just so honestly, this realization that like relational parts of identity withstand the disease process I actually was giving a lecture on a phenomenologic research project I want to do, and I did like a word cloud where I just asked people to put in, and these were not patients with ALS. It was people imagining that process. So, but I had asked them to put in like, who are you? Whether it's doctor, athlete, friend, mom. And then we deleted all of the items that would change with this disease process. And the things that were still there were all relational. And it made me think about like, gosh, it's so interesting that people who, I think that people who are able to maintain those relationships and find new ways of helping them to remain strong are, in my observation, those seem to be the people that do the best as well. And the deterioration of relationships seems to be the number one concern that people bring up as they approach like end stages of disease processes.
Mm-hmm. Yeah, so maybe that suggests helping people notice the aspects of who they are that aren't touched at the same level by the illness, and stay constant. And you mentioned relationships seem to be a big one. So thanks.
Yeah,
that's amazing. Yeah, thank you all for the comments. So just to talk about this just for another brief moment, there can be a wide variety of responses to a diagnosis of ALS. And also, and I welcome your thoughts on this too, it seems there are many stories of people who find ways to adapt. There is literature that indicates that about half, 40–50% of people diagnosed with ALS and their care partners experience some emotional distress after diagnosis. And again, that doesn't mean they aren't resilient. We can teach skills that help empower people to harness their resiliency with this new information. So the work I'm doing and the project I'm developing is based on this program called Recovering Together. Amber mentioned it briefly in the introduction, but it's a collaboration between the Department of Neurology and the Department of Psychiatry here at Mass General to deliver a resiliency coping skills program for people who've been admitted to the neuro ICU and whoever they identify as their primary care partner, with the goal to address emotional distress and improve outcomes throughout their course of recovery. I've been a clinician on this trial for 2 years, and let me move to the next slide. There's good evidence so far for the intervention. Right now it's at the efficacy effectiveness stage, but preliminary data show it improved symptoms of depression and anxiety in participants, and those effects were sustained at 12-week follow-up, and also helped with quality of life. And this was for both the patient and the care partner. And so the goal of Resilient Together ALS is to take what we've learned from this program in the neuro ICU and collect information to adapt it for this patient population with the hope that we can teach skills to help mitigate or prevent chronic emotional distress and preserve quality of life, both in the patient and whoever they identify as their primary care partner over time. This work is informed by these theoretical frameworks. So the Transdiagnostic Framework for Neurodegenerative Disease takes into account contextual factors, individual and dyadic factors to understand dyadic adjustment and identify targets to support adjustment over time. And then, Sarah, you were just talking about meaning making. So we also draw from the meaning making model for this adaptation, recognizing that a stressful life event can create greater discrepancy between one's global sense of meaning and one's situational sense of meaning, and helping them to leverage skills that bring greater congruence between their overall sense of meaning and what's happening for them in their lives right now. I see something in the chat. Let me just see what this is. Oh, okay. Thank you. Sounds great. Okay, so yeah, building off the meaning making model, we're drawing from, well, first of all, I just want to back up a little bit. Viktor Frankl developed what's called logotherapy based on his experience as a survivor in Nazi concentration camps, and noticing the powerful influence that meaning making can have on adapting in incredibly difficult circumstances. You can see the quote here: "Those who have a why to live can bear with almost any how." So building from that, there's an intervention called meaning-centered therapy that's been developed and tested a lot, I believe predominantly among people with cancer, and other forms of serious illness as well. That's shown evidence to help with improving one's sense of meaning and spiritual well-being. There's evidence for anxiety symptoms, and as well as, I think there's a study about physical symptoms too. So it's shown benefit among people with serious illness, and we're hoping to draw from some of that in this adaptation for people with ALS and their loved ones. So right now, this work is at NIH stage model, stage 1, so 1A. So the idea is we're modifying and adapting an existing intervention. And the next step is taking in qualitative feedback from that we are collecting from providers as well as patients and care partners to develop a first draft of the intervention and test it in an open pilot. So this just kind of summarizes what the two initial aims are of this work. And I'm going to go ahead and talk a little bit about some of the qualitative findings, and then based on what's of interest to people, we could also talk about some case examples. But we did an initial pass on the data using rapid data analysis. We're also going to go through dyadic data with full qualitative coding and analysis. So there's more to learn. So these are just preliminary findings. I want to highlight too, in doing this work, there was a lot of work put into relationship building with the Healy Center here at Mass General to be able to, you know, work with patients and loved ones and get their input and the providers as well. So things like presenting to the clinic, shadowing some of the providers, routine setup meetings with some of the staff, offering co-authorship on manuscripts. And I also do individual and dyadic therapy with referred patients from the clinic. So that was all part of building this collaboration. And these are just some of the initial feedback that we got from dyads and clinicians. So dyads talked about the process of trying to figure out what was happening with their bodies, and that described it as a confusing journey. A quote exemplifying this is one patient, it was a care partner, said that his spouse was very fit and good at hiking, but she was tripping a lot, which was unusual. So kind of identifying like how symptoms can kind of build up over time. And then a lot of them described like going to multiple providers and doing multiple tests before finding ALS. They talked about things like disrupted plans. So one person shared about wanting to tour North America in a camper van, and then that changed once this diagnosis was given. And then we explored what emotions came up for people with this diagnosis, and you can see some of the keywords highlighted here: very emotional, overwhelmed, uncertainty, guilt, anger, and this could vary amongst the participants based on, you know, their age, their life stage. Sometimes there was disagreement or tension between patient and loved one about, okay, now that we know what this is, how should we navigate forward? They also described that there was a desire for more behavioral health providers who had an understanding of ALS and could work with people who have this diagnosis. Providers also shared that they observed emotions, you know, when working with people clinically, and it can be, you know, a lot sometimes, just the emotions that are coming up. We also asked for qualitative feedback about the program itself, like a working outline of what we're thinking of offering. So dyads asked for things like practical resources as an addendum to the program, like, you know, guides for helping with navigating finances, wills, end-of-life decision-making. They talked a lot about help with navigating relationships. So how and when and with whom to share a diagnosis, how to navigate accepting help. So some people talked about feeling a sense of guilt with that, or feeling overwhelmed by trying to, you know, tell who and what they need, or even identifying what they need. Navigating uncertainty. So help with living in alignment with what your values are while making room for change. And a lot of people mentioned that humor and hope were really important and might look a little different for everyone. So that was feedback we received about the program. I also explored with them aspects of spirituality and faith. So, and how that may or may not, be potentially part of this program or an addendum in some way. And so there seemed to be, potential interest in this exploration and an open-ended, patient-centered, sensitive way. So also, different people described different sources of personally identified spirituality or religiosity, ranging, from a specific organized religion to other things like nature or having a meaningful role that felt like an expression of their lived legacy and a legacy they hope to have with people when they're no longer here. And they did talk about meaning as a way to explore these matters in sort of an open-ended way where, perhaps a particular religion or spirituality point of view may come up, or it might manifest in some other way, but it's a way of exploring these topics, again, in a patient-centered, sensitive way. They also, the little green guys kind of off here, they also, just gave feedback on, and some of this was a mix of, either from dyads and or clinicians, just being mindful of things like mental health stigma. So presenting it in such a way that's sensitive to that, using plain language, being really flexible with scheduling and timing, being sensitive to, the clinic is a very busy place. So offering it in such a way that makes it easy for clinicians and dyads to participate while allowing them to stay focused on the clinic visit itself. So overall, there was strong initial expressed interest in this program. And the next step, as I mentioned, is we're working on doing a deep dive into analyzing the data and incorporating what we learn into a first version of the intervention. So that's where we're at. And I just want to pause here. I can go into talking about some case examples really briefly, and I'm mindful of time. I think we're 1:30, so I just want to check if there's any questions coming up so far or anything anybody wants to explore for a moment. I think I see here. So let me check. I do see
Dave's hand up.
David, yeah.
Yeah, thanks for the presentation. I guess I'm just curious. I can very easily see this looped into an interdisciplinary clinic. I'm curious if you think, how well it would work either as a standalone. It sounds like you do some kind of, for lack of a better word, consulting on the side in terms of working with dyads. Do you think that, that ALS specialists that are not a part of an interdisciplinary clinic would still have access and would be able to utilize this type of system in their practice? Or do you think it's going to be something that would probably be exclusive more to interdisciplinary clinics? Thanks.
Yeah, thank you for that question. So one thing I didn't mention earlier is the way we're developing this. The Recovering Together trial in the neuro ICU, the way that one works is the clinician goes for that first session to meet the patient and care partner at bedside while they're still in the hospital. And then the remainder of the sessions are done over Zoom after they've discharged. And so the current working version of this program that we're thinking of trying is a totally virtual one. And that's for a number of reasons. We got feedback, that clinic visits are really busy. We got feedback that some of the people who come to clinic are coming from far away. So there's a geographic limitation there that would make it hard to do face-to-face for a program like this. So all of that to say, as we are developing this and testing this, we're anticipating trying it out virtually, and depending on the results, if that works well, my thinking is that would make it more readily accessible potentially. But we'll also, see what we find as we try this out. I'm wondering if that brings up more questions or if that helps answer your question.
I've got one follow-up.
Sure.
I apologize for hogging, but I guess I'm curious, what is the cadence that you're looking for? So again, if you're going to an ALS clinic visit once every 6 months, it might be, or once every 3 months, it might be super critical to have touch points in the in between. And so, yeah, what are you looking at in terms of, the cadence there?
Yeah. So right now we envision modeling off recovering together as having a session for about 6 weeks. And the idea is, there's so much information to unpack. I'm realizing, I didn't mention this. The idea is we're hoping to reach people early on after diagnosis to support them through that initial adjustment period and teach them, these initial tools that they can have in their toolkit to help them navigate that adjustment period and then feel more comfortable and confident using them over time. And so that's the current way we're thinking of structuring it.
Okay. And so, sorry, just to clarify, was it every 6 weeks, or was it like
once a week for rough 6 weeks. Yeah.
Thank you.
Yeah, thanks for the questions. Okay, I'm just double checking this any more raised hands. I don't see.
I have a quick question, Christina.
Please.
You might have said it, but I forgot. How long is each session again?
Oh, yeah. So my experience so far is that they, within a research study, they're usually 30 to 45 minutes. And so we might, play around with that too, if that's the initial thought is for length of session.
There's a question in the chat.
Yeah. So
from Monica.
Oh, yes, we do have a working outline of the sessions. Still refining it, based on the qualitative feedback. So it's not, we have like that initial recovering together template, but there's a lot of work to do to take in feedback that we got in the qualitative interviews to adapt and tailor it. So, yeah. And maybe some of these case examples will kind of bring up some of the content too. Okay, so bringing clinical intervention research to life. So, you have your outline on paper and it's all really planful and thought out and, informed by theory, and that's amazing. And then the next step is to have that live human interaction where the people who want to participate get exposure to learning the skills. So the idea is building a therapeutic relationship is really important with these interactions, and that calls on things that anyone who does is a behavioral health provider learns. So things like bringing to the session genuineness, empathy, unconditional positive regard, all to create a safe, welcoming space for the learning to happen. And then with that kind of approach to the relationship, bringing in the specific skills and tools. And referral is really powerful. So, if a dyad hears, oh, my doctor thinks this is something that could be helpful to me, that can really help them feel more comfortable and confident with trying these things out. So that can lay a nice foundation for them to be able to engage and learn what they would like to learn. In the interest of time, because I see we only have 15 minutes, I'm not going to dive too much into this. It's just a little image of biopsychosocial spiritual case conceptualization. So how we think about all the different components of a person and how that might impact how they're presenting. So I take that into account when I'm working with someone. And then here's a dyadic case example. So Megan and Frank, excuse me, I worked with them recently. They're a married couple.
Hey,
Oh, please. Did someone-
stop.
Was there a question? Okay, maybe someone accidentally unmuted. So they're a married couple. And so kind of learning about them, learned that they both experienced trauma in childhood. They both grew up in under-resourced conditions. One of the partners shared that they had a comorbid mental health diagnosis. Importantly, they also shared that their particular spiritual views and religious identity were really important to them. And they also live in a multi-generational household. So when thinking about taking the skills of this program, I'm working with this dyad, just like trying some initial version of this informally as we're developing the manual and getting ready to test the program. I took into account things like family is very important to this dyad. Also making it a safe space for them to freely express their spiritual and religious views, and how that affects their views of navigating the illness, how that affects their coping, how to leverage those views in a way that supports their coping. And then another component that came up was using some of the skills like mindfulness or communication to help them with navigating the effects of this illness on intimacy and finances. So that is one example. And then I'll just, I'm a little torn because I'm going to make time for discussion here. I'll just say very briefly about Nick. His presentation was different. So instead of working with Nick in a dyad, I worked with him individually. When he was referred to me, he was at a later stage of illness, and there was some uncertainty about his presentation, his low mood, whether that was primarily symptoms of depression or some possible early signs of FTD or a combination of both. So in that case, the focus was on exploring behavioral activation with him, helping him to identify what he finds either important and or enjoyable to build more of in his life in a way that fits with his current functional status. There was also work supporting good communication in sessions because Nick needed to use a voice amplifier to speak. So learning things like simplifying communication to make the flow as minimally burdensome as possible while still making sure that he felt supported and he was given space to express himself and feel understood. So his course was very quick. So this was a shorter round of therapy. Unfortunately, he declined and then passed away. But in that time, we were able to work together. Some of the rewards were seeing him light up, saying like, I would really enjoy inviting a friend over to come spend some time with me, or even him sharing about his legacy of volunteering and how that felt really powerful and important to him and made him feel good about himself. And also learning about how to support him and keep good flow of communication between him and his family and the medical team as things were coming up. So with the time we have remaining, we can just open it up for further discussion, or we could talk about what comes up in the room when you're working with patients and families, and what strategies you've noticed are helpful for helping them with emotions or even stuck points. So it's whatever's coming up for people. Yeah. Thanks, Lynn. We appreciate that comment. Any see Sarah's comment too. Who doesn't say? Let you speak of since I'm a huge. Oh, thanks for putting that resource in there, Sarah. Yeah. Oh, Trinity, you have your hand raised, please.
Yeah, I wanted to just mention, I think, a little bit further, and again, because we deal with people with ALS who are using a communication device or in the need of the communication system realm.
Yeah.
We find that somebody with motor neuron disease using a communication deficit or using a communication device has an extra layer of finding a provider who is willing to interact with them in this realm. I've heard everything from, if I can't hear the tone in your voice, then I won't be able to understand the emotion of which you're using to speak to me. So they're told no, they can't receive these sorts of services. So I think I would love to be able to, add one extra layer to this idea of looking at ensuring that these sorts of programs are also including education for the provider on how best to interact with these individuals.
Yeah.
Various forms of communication, be it understanding their communication device, understanding their limitations, understanding more effective ways, for example, giving questions ahead of time to allow them to prepare to participate.
I absolutely love that. Yeah. And I welcome any and all feedback on that. This truly is a work in progress where these nuances, it's really a gift to be working with the patients and their families, because that's where these kinds of things come up, and it's such an amazing opportunity to learn. So yeah, I welcome any feedback on how to make it as accessible to as many people as possible. Just checking everything else. So I guess I could share, you know, I had little tips in here about things that can be offered on the spot if you're working with someone who's, showing up for some kind of clinic appointment or research appointment and they're showing some distress. Things like slow, deep breathing or guided imagery can be like very nice on the spot tools that you can offer. There's great mindfulness apps. I know that Insight Timer is one that's free. It has like a paid version, but you can also download it for free. So you can pick and choose if you want to subscribe or not. There's also the UCLA Mindfulness Center website, and they have free recordings there. So just like some little tools that can be offered to people if they are wanting some additional options for managing stress and just feeling like they have additional support with that. And also just being present in the room with them is so huge. Just being there, which is something you're doing day to day in this work already. And yeah, because of the time, I guess there might not be much more time to talk about that, but I can share. So this is where we are hoping to go with this work. First of all, I want to thank my mentors who've been guiding me in developing this research. So Dr. Branchano, Dr. Lindenberger, Dr. Park is also getting involved. And really in the very early stages of this work, I was very honored that Dr. Curtis looked over drafts of grant proposal and manuscripts and offered feedback. So really grateful for that and wanted to name that. And the hope is, with the open pilot, depending on evidence, we'll be able to build off that to develop this further. And yeah, I think I had questions for the group, but again, I'm mindful of time. So I'll just stop there and open it up for anything else that anyone would like to discuss with the time we have left. Oh,
Oh, go ahead, Sarah, please.
No, I just was going to say I'm so grateful to hear about this. Anything that people are doing to try to support folks with any disease, but then especially, like what Trinity was pointing out, it's such a big, big struggle when people can't communicate with their voice. And it's something that I think about a lot, trying to connect people. We're also at our center looking at a study and a potential thing we may do that involves compassion and meditation, because people can't a lot of times engage in typical psychotherapy. And I know I put that resource there, which is really great. But yes, Trinity, I echo the concern and just folks not knowing exactly. We're in a metro area, and so we have a little bit more options, and we have more people, and we have some groups that actually go out to people's homes that are focused on this and sort of understand that. So we in this sort of little enclave have like access to that, but that's not everybody. And so I'm really excited to hear about this and would love to hear more as you continue to go through, and thank you for your work on it.
Thank you, Sarah. That sounds amazing. The programs you're developing too. Thank you.
I just was wondering, I don't know if this is a quick question, but is there a network that exists or a reference network so that that's most of what I've struggled with, is finding the referral option. Like I have a patient in New York and I can't get them much, like forget about just finding forget about like the patients that Trinity was referring to who cannot communicate with using voice, which is like the hugest barrier. But just even, therapy, or like any kind of, support that way. Is there an existing kind of, other than sending people to psychology today, is that what other people are doing? Is that, yeah, okay.
Yeah, I'm so curious to hear what other people are doing, actually.
I know I've talked a lot, but I can tell you what I do briefly. Psychology Today is a big part. I've also just tried to network in our general geographic area and connect with therapists that are focused on supporting people with any type of grief, illness. Most people aren't ALS specific, but therapists can learn about ALS as long as they got the skill set for helping to support with, these serious illnesses. They can learn about the ALS part. But especially in New York, you should really look at the AEDP roster that's there. I'm such a huge fan of the psychotherapy type for supporting folks that are engaging with this. I think it's really, really great. So especially in metropolitan areas, I think you probably would find somebody there. But I don't think there's anything like, there's not like a formal network. Psychology Today, I think, is going to be your best bet.
And the hope is, depending on what we find with this program, that this is something that ultimately could be shared with a wide variety of behavioral health providers, that they could feel comfortable learning and then being able to use in their practice. Thank you for sharing that, Sarah. And then it looks like Lynn has hand raised.
Hi, Christina. Thank you for sharing your work with us. Two things. One, have you run across the work of David Kessler?
I don't think so.
He worked with Elizabeth Ross to develop a 6-stage of grief called Finding Meaning. And he has a book by the same title that I actually listened to on Audible that's very much reinforces what you're saying.
Wow, amazing.
The second thing is that I'm part of a INPCS specialist group, rehab specialist group, PTOT, music therapy, art therapy. And it's been a struggle even within our own professions to help our colleagues understand how they can support palliative care without being the initiator necessarily, but a lot of times in the course of our sessions with them, issues do come up. And so again, considering training in awareness of these skills and how just the conversations you have and the suggestions you make of where else to find resources, educating those professionals to be able to refer to resources that could additionally help them.
Yeah.
But yeah, keep up the great work.
Thank you. Yeah, I was thinking back to Sarah's question. I know in our area there's Compassionate Care ALS, and they provide resources. And I hear a lot of people say how amazing it is to work with them. And so, and kind of like Sarah, you were saying about how you networked within your community. So it does sound like there's maybe a local element, and then hopefully over time there could be, a referral network. That would be incredible. So thank you both, Sarah and Lynn, for your comments.
Well, I think we're at time, and Christina, this was amazing. I think it's work that's really necessary, and we all clearly feel like it's filling a gap. So thank you so much for sharing with that and for doing all the work that you're doing. And we're looking forward to learning what you learn and learning how to apply it in our clinics in the future. Thank you all again for joining. Really appreciate it. And keep a lookout on the website for the next meeting sets.